and welcome to our presentation about undernutrition in gymnasts and how that affects the female athlete triad. So in sports where high power to body mass is important, such as gymnastics, an increase in body weight can negatively impact performance. As a result, the life of a gymnast involves a combination of intense physical training and pressure to meet unrealistic weight goals in order to improve performance and/or visual appeal. According to Molina et al., the optimal training plan for an elite gymnast suggests 2 daily training sessions, 6 days per week. Those training sessions are usually split up into 1 in the morning and 1 in the afternoon, with the morning one being 2 to 3 hours, and then the one in the afternoon being 3 to 4 hours. This intense training combined with feeling the need to meet unrealistic weight goals can lead to low energy intake and undernutrition in gymnasts. According to Ciatris and Mamalezzi, there is a prevalence of 31% of eating disorders in female athletes and a prevalence of 62% of disordered eating behaviors in collegiate gymnasts. Undernutrition and low energy intake is the first component of the female athlete triad. The second component of the female athlete triad is menstrual dysfunction, which is caused by undernutrition. According to Clinchow and Pliley, these disturbances in the menstrual function can occur in 3 ways. The first is primary amenorrhea. This is the absence of menstruation by age 16. The second is secondary amenorrhea, which is the absence of menses for 3 or more months in women who have begun to have periods. And the third is oligomenorrhea, which is the menstrual cycle that lasts 36 days.
We looked at a study called the Onset of Puberty, Menstrual Frequency, and Body Fat in Elite Rhythmic Gymnasts compared to normal groups. That study was conducted by P. Clinchow and M. Pliley. They surveyed 45 athletes of a mean age about 14 and a half, just over 14 and a half, 15 Greek and 30 Canadian gymnasts. They were surveyed for the age of menarche, menstrual frequency, and training profile, so how intense or how often that they're training. The study did find significant difference in menarcheal age between experimental and control groups. The control group consisted of 78 individuals, non-athletes around the same age, about 14 and a half, 30 of them from Canada, and 48 of them, or 48 of them from Greece. The results were that the gymnasts got their period typically about a year and a half later than normal, and this was statistically significant at the 0.05 level in the study. If you look at table 1 below, that gives the basic demographics of the experimental and control groups. Like I said, mean age of about 14 and a half. Height and weight were kind of consistent. The only thing that stuck out was the percent body fat. The gymnasts had a significantly lower percent body fat than the control group. The gymnasts had between 14 and 16% body fat, whereas the control group had between a 21 and a 25%. Looking at table 2 below, compares the experimental group pre-menarcheal or menarcheal age, so whether they have started their menstrual cycles or have not. The biggest difference was that the percent body fats went up after you started the menstrual cycle. Same with weight, height, and training experience and frequency decreased.
As Isaac was talking about with menstruation dysfunction, I want to talk about some of the hormones involved in menstruation. And one of the main ones is estrogen. As estrogen is converted from androgen into estrogen in adipose tissue, this is difficult for gymnasts to do because of the high strenuous activity they do every single day. So there's not a lot of adipose tissue to convert the androgen into the estrogen. And with low estrogen levels, you can also get premature loss of bone mineral density, impaired endothelial cell function, impaired skeletal muscle function, and elevated LDL concentrations. So overall, this is not something we want to mess around with. We need to keep our gymnasts eating plenty of food to keep their weight up, allowing them to convert androgen into estrogen. And going on to the next slide, we're going to talk about some of the other hormones that are having issues. These are insulin, cortisol, growth hormone, insulin-like growth factor, and leptin. And so with insulin, we talk about a lot in class with diabetes. If you're not producing enough insulin, low levels of insulin, you have trouble absorbing hunger. And then with leptin, it is a protein or a hormone that regulates hunger. So if you're not regulating your leptin, you can have large hunger swings and eat a bunch of food at once, which is not good for someone who's undernourished. Now, along with pairing all of these together, you can have large dysfunction with bone formation, which can lead into osteoporosis, which Tim is going to talk about. And overall, with these hormone imbalances, you're going to have a lot of impedance on individual growth and the overall function of the body, which is not something we want to see.
So previously discussed about the female athlete triad, one of the characteristics of female athlete triad is osteoporosis. Osteoporosis, as defined in class, can be described as a decrease in bone mass and bone density, whereas you can see an increase in the spaces and increase in the porosity of the bones. As you can see in the picture that I displayed, right here is a normal bone, and on the right next to it, you can see the bone with osteoporosis. You can see the bone with osteoporosis is more porous and less dense than the normal bone. Osteoporosis affects about 10% of the total female population later in life. It is greatly seen in female athletes, especially gymnasts and high-intensity sports where females participate in. Females with a lower body weight are generally at a greater risk for the triad because they're mainly focusing on keeping a low weight and to increase their overall performance. Therefore, they're going to develop osteoporosis later in life. Osteoporosis is most commonly seen in female athletes due to the increased intensity placed on their bones and joints. The constant impact and compression of their bones throughout exercise or throughout competition is going to overall have a negative impact on their bodies, along with the decreased diet and the decreased weight that they're carrying themselves with. There's a rate of bone loss. It depends on a variety of factors, such as an unhealthy diet, an unhealthy weight, and an intensity. And as Maria previously stated, a exercise week for training for female gymnasts should consist of 2 sessions per every 6 days. There are also abnormal menstrual patterns that can lead to a decreased bone mass, and which is going to decrease the bone minerals, which ultimately is going to increase for a bone fracture with serious injury. And all those factors combined eventually lead to a decrease in bone density, which is then going to increase in your chance for osteoporosis later in life. So overall, you see a change in an unhealthy pattern in female gymnasts with an unhealthy diet and unhealthy weight management. Those factors combined are going to decrease the overall bone health, and as well as their overall well-being and overall full body health, which is going to ultimately lead to a reduction in performance, where you see a decrease in their numbers and scores during competition and even during practices. So really what you see is female gymnasts are sacrificing their health and their overall well-being to kind of fit the mold of what a female gymnast may look like, and to have that low body weight and great look to their bodies. To prevent or even eliminate the effects of osteoporosis, it is important to identify some signs that can occur in female gymnasts. For example, the Russell sign. The Russell sign consists of skin lesions, abrasions, or smaller lacerations, or even calluses on the back of the hand, which could be due to forced vomiting, putting their hand in their throat, causing them to vomit, which is going to decrease their body weight. It is important to identify such risks because it can benefit their bone, their muscle, and their overall health, which isn't going to have any deteriorating effects on their bodies. To treat osteoporosis, there's many approaches you can take to this. If you want to supplement, you should supplement calcium, estrogen, anabolic steroids, or even vitamin D. For calcitonin supplementation, calcitonin may increase bone density by up to 5 to 20%. And that's important to understand for female gymnasts or female athletes overall, because it can reverse the effects and even lessen the effects for osteoporosis development later in life. By supplementing estrogen, this is going to decrease the bone loss while increasing the bone density, which is going to eventually eliminate or prevent osteoporosis. This is important to know for female gymnasts because it's going to allow them to regain their health and regain their overall performance, even if they have already been in a downward state. It is very important to note that you should not compromise the intensity of the workouts. It is important for the athlete to know what suits them the best and how many times a week they should be completing high intensity workouts or even minimum intensity workouts. Those workouts, by compromising the intensity, could lead to a decreased performance and decreased competition results, which is the whole reason why female gymnasts, while they're competing, is to win, to get first, and to put up good numbers. So to get rid of this, it is important for them to maintain a healthy diet and maintain a healthy weight. So overall, this can all be prevented by taking the right steps in the right direction to living a healthy and happy lifestyle.